very pleased to be here and talk to you a little bit about orthostatic intolerance. That's sort of the showcase for dysautonomia. And we use it at these measurements or tests for orthostatic intolerance, even in patients who don't have symptoms of such, because they are thought to have other parts, dysautonomia involving other parts of their body. So, by the way, everybody who wants a copy of the slide set, I am told by Caitlin that they can just ask for it and get it. So I'm going to go through this quickly, and you'll probably not be able to absorb all of this at one sitting. That is, if you really wanted to absorb it. So there are two types of orthostatic intolerance. Orthostatic intolerance just means that people are uncomfortable when they stand up for any period of time, and any symptoms that are associated with that would be icing on the cake. And there are two types. One is called POTS, postural orthostatic tachycardia syndrome, and there are discrete criteria for that, as you can see on this slide. And the other manifestation of orthostatic intolerance is syncope, and that definition is also on this slide. And it used to be said that you can only have one or the other. You don't get both. So people with POTS are not supposed to faint from neurally mediated hypotension, and people who have a neurally mediated hypotension are not supposed to have POTS. However, just that picture, I don't know how many people here know who Leslie Howard is. Probably no one. That's too bad. He's an interesting character. You can look him up. But this was a grade B movie. So the twains do meet. In fact, you can have both POTS and neurally mediated hypotension, but the incidence of that on upright tilt table testing is only about 6%. So the vast majority of these people actually present with one or the other. So issues about dysautonomia go back up to the time when God saw Jonah faint as the sun beat down upon his head. And these biblical references, of course, just show you how long we've known about people who have loss of consciousness without any obvious reason and spontaneously recover. The issue of the history you can see here in the slide, but the issues that I think are sort of important and informative. In 1871, Dr. DaCosta described irritable heart. These were in Civil War veterans, and they had dizziness, palpitations, tachycardia, diarrhea, chest pain. I mean, everything that you think might be POTS. Or as I think we can see in studies coming up now, that there's some overlap between post-traumatic stress disorder with dysautonomia as well. Then there was a very formative paper by cardiologist Thomas Lewis in which the term soldier's heart was applied to people, young soldiers in World War I who were fainting after having chronic illnesses or an overcrowded situation. So there's a lot of reasons to think that there could be outside influences that bring about syndromes that are indistinguishable from dysautonomia. Finally, we have a first report of postural tachycardia in 1982, and then the report of using the tilt table test to really coin the term postural orthostatic tachycardia syndrome, which was as recently as 1993. The first clinical use of a tilt table test, however, was in 1986. And this use was to look at patients who had unidentifiable causes of syncope. And they put the patients on the tilt table test, and they found several that had asystole for some time that were associated with their syncope. Matter of fact, 67% of the patients who had undefined syncope, in fact, had a positive tilt, and they put pacemakers in them on the basis of the tilt table test, and they had pretty good results. So that's the first clinical use of a tilt table test. The tilt table itself was used for research purposes, looking at the physiology of the autonomic nervous system way in advance of that. Here's a patient who has, as you look at the pictures, some mild acrocyanosis when she stands up. It goes away when she lies down. Another patient with EDS, and the typical tilt table test with a normal set of graphics on the left as you look at it, and you can see on the right, when you look at that vertical line and you see the red manifestation of the heart rate, the vertical line is the onset of tilt, and you can see that within a relatively short time there is a significant increase in the blood pressure and the heart rate, which is sustained over a fairly long time. Also, there is a minimal decrease in the blood pressure during that period, but some. POTS is probably exists in some 3 million people in the United States, and it has a lot of associated disorders. Associated doesn't mean causative. It means just what it says, associative. It means you find these things in patients that have POTS, and they may or may not be causative, but we really don't know for most of these things. It's a little bit easier, perhaps, when you see some anatomic compression of the area of where the autonomic nervous centers are associated with these kinds of symptoms. And then when you remove that compression, like they do in Chiari malformation surgery, as has been discussed already, the symptoms go away in many, but not all of the patients. Recently, there's been a couple of interesting things. One is in the association of stress-related disorders and the subsequent development of autoimmune disease, and you'll see how all this stuff comes together. So this is a large number of patients, and you can see as you're looking at the left a huge listing of different kinds of autoimmune syndromes. And if you look at the to the right of that panel, you'll see a line going down the middle of those. I wish I did it. Oh, wait. Yeah. So this is the line of identity. this means that there would be equipoise or no difference between whether the patients had stress or not in terms of the development of autoimmune disorders. And you see all these that have their little mean in the middle, and then they have the confidence intervals. All these that lie to the left of the line of identity mean that they're significant statistically. So these are a wide spectrum of these disorders, and I think that it really makes the case. On the other slide, there's too much to really, other half of the slide is too much to really present. But in short terms, there are autoimmune abnormalities associated with some forms of dysautonomia, and they are seeing more and more of these all the time. And the statement, and this is from a paper that is online, it's not yet been published, but which has looked at a number of these, and they were related to certain communicative binding sites that affect in the most popular or frequently recorded autoimmune abnormality, the G protein associated with acetylcholine receptors. So they make the statements that, sure, there's a lot to know about this, and there is a lot of interest in this, but there is no reason as of yet to think that one should be using immune therapy on patients with these disorders. Now, on the other hand, at Hopkins, Mark, you probably know about this, there's a gastroenterologist who has uncovered an interesting syndrome which involves the gastrointestinal tract, hypermotility of the joints, autoimmune problems, and autonomic abnormalities. And he is starting a protocol that will take people with that syndrome called JAK-A and treating them with intravenous immune globulin. So we'll see where that goes. Here is a long list of symptoms that sometimes occur in POTS patients. And you can see that a lot of these, by fact and by inference, lead you to think that there are a lot of autonomic targets other than the blood pressure and the heart rate that are affected. And the blood pressure and the heart rate in the test that we look at in the tilt table test, for instance, are just easy ways of looking at abnormalities or not. So we get a lot of GI people referred to us for tilt table testing, even though they never had a faint or they don't have orthostatic intolerance, but what they do have is the thought that they have a GI autonomic disorder. There are some things confused with POTS: drug reactions, anemia, adrenal failure, carcinoid, anxiety disorders, deconditioning, and I may forget, but reconditioning people with POTS is an extremely important part of any kind of therapy, and it really needs to be done. Exercise of what's ever tolerable and building up shortly is a key component of any treatment pattern. Dehydration, hyperthyroidism, pheochromocytoma, And in the end is inappropriate sinus tachycardia. And that is people that have an elevated heart rate during the day and night and not specifically increased when they stand up, but the heart rates are high, in general over 100 during the day. And this is also thought to be an autonomic manifestation. Some people have suggested grading orthostatic intolerance, 0 if you have no orthostatic intolerance, and then going up to 3 depending upon how well you can tolerate being in the upright position. I haven't seen this used practically, but it's an interesting thing. It's like your sleep number. You may find some use for it in the future. The prognosis of POTS, I've looked at all the information that's available, and this is a summary of that. And it suffers because it only reflects patients that have been carefully followed for the most part. So, and that's a small portion of the 3 million people or so who have POTS in this country. But it's clearly a chronic condition, not itself associated with increased mortality. About a third of the patients in one study no longer had a rise in heart rate on the tilt table test after 1 year of follow-up and felt well. 60% of adolescents of a study in adolescent patients with POTS improved at a mean of 20 months. So these are long-term follow-ups we're looking at. So when we start somebody goes to a doctor and he says, well, I'm going to start taking care of you for this. Well, should I be better in 2 weeks? Well, you might be better in 2 weeks, but you might not be as better as you're going to get at 20 months. And then in another very small study, but one that it's interesting, 1/3 of the patients at 1 year were completely asymptomatic. Half were significantly improved, but 12% were still very symptomatic. And of the total, 62% remained on medications. So this is the tilt table test. It's a pretty easy thing, really. There's that table, obviously. Can't be a tilt table test without a table. And this thing just goes up and down, as you see in a minute. There are a whole variety of things. We usually do 2 stages. The tilt table test itself, if you're only looking for POTS, should last no longer than 10 minutes. And that's why insurance companies don't pay for it. So I have to make sure the fellow puts in the diagnosis dysautonomia, because if you put in tilt test or POTS, you're out of the game. You'll see that for neurally mediated hypotension, however, we end up after 45 minutes if the patient hasn't developed any signs of neurally mediated hypotension. We try to provoke that by giving, we use isoprel, or isoproterenol, I should say, and that usually increases the heart rate a lot, and it scares the patient a lot, and it's an adrenaline a mimic, and that's a good way to look at a good way to provoke a drop in blood pressure if it's going to occur, or heart rate, I should say, as well. Note in this picture that these people are really bound down to the tilt table test. Part of that is because we don't want them falling off if they do faint, but the bigger part of that is we don't want them to use their legs, because the whole thought of the pathophysiology of POTS is that a good portion of their intravascular volume, maybe as much as 500 cc's, goes to the lower parts of the body when somebody is in the upright position. And clearly, if the autonomic nervous system is defective and doesn't get that back up to the heart, a lot of things happen as further reflexes take over. But it turns out that you don't need an autonomic nervous system to get the fluid back up to your heart if you have used the muscles in your legs, because they can milk the blood back up out of the veins if they're being flexed and stretched regularly, like walking or playing sports. Now, that's one of the reasons why you can take a kid with neurally mediated hypotension and they'll play a game, but they won't faint at all. But as soon as they stop, they faint, or within a minute or so, because while they're running, they're pushing the fluid up. And if, let's say, they're playing a game that's very active, like soccer or something like that, they're sweating and they lose fluid more. So they're really primed to be to have a positive test for a self-administered positive test for neurally mediated hypotension if they stop and don't sit down. Who gets a tilt table test? Well, a couple of years ago I looked at this, and I've been afraid to look at it again, but we do about eight or nine of these tests a week, and this is in cardiology. And why is a cardiologist involved? That's a good question. They are traditionally involved, but the main reason they involve is we're looking for people who faint, because a lot of those people faint because they have heart arrhythmias that have nothing to do with neurally mediated hypotension, for instance. And these people present with headaches, pre-syncope, dizziness, abdominal pains, disequilibrium, neuromuscular disease, seizures, falls, hyperhidrosis. I've done people who have electrocuted themselves accidentally, and people with concussion. And by the way, in that very first presentation of the tilt table test showing postural orthostatic tachycardia, 3/4 of the patients had chronic fatigue that tested positive for that. There is an association between chronic fatigue and POTS, as you all probably know. It's not one-to-one. They're like these Venn diagrams that overlap each other, but it's something we see a lot. And the people who refer to us are other cardiologists, internists, neurologists, but increasingly GI doctors, interventional radiologists, and thoracic surgeons. Why interventional radiologists and thoracic surgeons? Because they're interested in cutting nerves or ablating nerves that are associated with hyperhidrosis, for instance. And they're interested to see whether we can find any other evidence of dysautonomia. So most of the people we see have had symptoms for months to years and have seen more than one caregiver, and most referrals to us for a tilt table test are usually from frustrated doctors who don't know what they're seeing or how to treat it. Although I will say that in the reasonably long term I've been doing this, there's been an increase of awareness, even from the nurse practitioners and the PAs that are out there working with the doctors. It's interesting and it's good. But many of the patients are disappointed with the medical care, and they're very frustrated. Dysautonomia is the most frustrating disorder you can have. And a lot of physicians don't have the frustration tolerance to keep taking care of them. So you see a lot of pushing away. And it takes a long time. You saw, I showed you that it can take 20 months before everybody that could get better gets better. And the problem is how to treat them. And everybody knows plain salt fluid, sometimes fludrocortisone or Florinef, sometimes midodrine. And beyond that, there's sort of like a roadblock. Well, there are other things, and I'll get to that in a minute. These are just the same kind of criteria and what goes on in a tilt test. You can read that if you're interested. How many people here have had a tilt test? Wow! You had 2 of them. Okay, so one thing you should know about the tilt table test is that its sensitivity, sensitivity means how good it is of identifying all the true cases of the problem you're looking at, and the specificity, that is, what's the incidence of false positives, are not great, and they're made a little bit better when you do use a provocative agent. So here you see, here's just a plain old tilt test. It's a very good specificity, but not very good sensitivity. And when you do all these provocations, you increase the sensitivity, but you decrease the specificity a little, just like any other test. Oops. Here's another one that you need to take home. These are therapeutic possibilities. This lists pretty much all the medications that you can use. It also suggests on the bottom a stepwise progression through the different ones. They don't say, these are just pharmacologic things. They don't say things like exercise, and I cannot underestimate how important exercise is. The other thing is that I have all my POTS patients and many of my neurally mediated hypotension patients where bicycle racing, don't go there, but I tell them to go to a bicycle store and they say, what, you want me to buy a bicycle? No, I want you to buy the spandex pants that bicycle racers wear. It's tight, it goes from above the waistline all the way down to the ankle, and these are the best constricting wear that you can have. Constrictive hosiery is really not good. And if you buy what women currently think of as tights or I don't know what they call them now, but they're not tight enough. They're comfortable. I don't want them to be that comfortable. And by the way, the heat exchange between these are pretty good. So you can wear something over them if you're shy, and you can wear them during the summer. So this is a tilt table test. This is a 77-year-old man who had a lot of disorders. He had aortic stenosis, and he syncoped when he was in his car driving, and he had a cath, he had an aortic valve replacement. He also had a CABG at that time because a bypass because he had some coronary disease, and he got a dual chamber pacemaker, and then he had another episode of syncope after all of that, and this represents his situation, and it's typical. In that the blood pressure was sort of high in the beginning, and then as he's on the tilt, he drops to 0 at the same time that his heart rate drops to 0. So he had the typical vasovagal response, which is a drop in heart rate and a drop in blood pressure. Here's an 18-year-old who had atypical seizures, and you can see that she has this long period of asystole. Now, that doesn't mean we treat them with a pacemaker. If you're over 40, if she was over 45 and she was having this, that would be a pacemaker, especially if she didn't have any warning. But we try to train our patients to look out for prodromal or warning symptoms because they almost always occur. And if they have it, they know how to take care of it. And I also tell them about driving. You're not standing, at least most people are not standing when they're driving. Some of the teenagers I'm not so sure about, but even if you're sitting under the perfect storm is you worked out in the gym, you didn't have any breakfast or anything to drink before then, you sweated, it's very hot, there's no air conditioning in the car, you're driving home, you're having a menstrual period, it's really hot, and you had an argument with your husband, kid, whatever, so you're stressed. All those things, that's sort of a perfect storm for somebody to have such a problem. And sometimes doing a tilt table test, you find something very unusual. In this case, I don't know if you can realize this, but these ST segments are very elevated compared to what it was after and before. So this is a sign of cardiac ischemia. And what happened in this patient was she had, I'm not sure it's a he or she, but that patient had spasm of his coronary arteries, which can be brought about by an autonomic discharge, just like it can cause constriction and relaxation changes in all the vessels. That's why Raynaud's syndrome is part of the disorder. Now, there are a lot of clinical tests for autonomic function, and the tilt tests are just the easiest ones and the most accessible. There are cold pressor tests, there are heart rate variability tests, there are a Valsalva test, and there are sweat tests. All of them have a role. None of them have really been any better than the other. Of course, the ultimate test is the lie detector test, which is basically what we do with the tilt. And of course, they do it also with galvanic skin resistance, which is it's a stand-in for looking at sweat. If you do a bunch of these tests, you can sort of characterize POTS into a number of classes that is thought to have or may have some relationship to the pathophysiology. And if you do that, you could argue that you could pick out therapeutic agents that are most likely to help that problem. And something like this, to fully characterize patients like this and then try to treat them with what we most often treat them with anyway, is a big deal and not done very commonly. So, but there is some reason to think that POTS is a conglomeration of a number of different pathophysiologies, and that they may need special treatment with regard to the pathophysiology as everything else does. Just talk about syncope. Somewhere between 20 and 50% of the entire population of the United States and every other country will have a faint at some period of time. The usual number I get is about 30% over their lifetime. And it's kind of interesting because if you go in with the syncope to an emergency department, you'll only know what the likely cause of it is in 76% of the time before you're discharged from the hospital. So the usual rate occurrence is 18 to 40 per thousand population. Of these, 10% have a medical evaluation. The other 90% just go home and sleep it off. And only 1% of that total are ever hospitalized outside of just the emergency room. And this cost, syncope costs almost $2.5 billion a year for its management. So it's nice. By the way, the most frequent cause of syncope is neurally mediated hypotension. Single most. Now, there are other vasovagal events that cause syncope as well. There's micturition syncope. It's for old guys with prostate problems often. Straining at bowel movements, same kind of thing. Fright. I had a young nurse who was scared, not a nurse, a nun, who came home one day and her nephew jumped out from the closet, scared her, and she collapsed, and she never regained consciousness. So this could be a big thing. That's why I never scare anybody. I usually wear a mask. There's also swallowing, deglutination can cause syncope. Cold things or big meals are typical of that. Visual, like seeing blood and fainting, everybody's heard of that. So we usually do the tilt table test. Sometimes we actually measure cerebral perfusion. And we can do that with, somebody actually mentioned it before, with transcranial Dopplers. And when you see the typical tilt test, this is a normal, this is perfusion, this is the blood pressure, this is the heart rate. Now, here's a typical person who dropped their blood pressure, dropped their cerebral perfusion, and had a positive tilt test for neurally mediated hypotension. Here's a patient that had a tilt. The heart rate went up, but not enough to be POTS. The blood pressure didn't change much at all, but cerebral perfusion decreased. So we know or think now that there is a possibility of having people have a drop in cerebral perfusion due to some kind of steal effect in the cerebral vascular system without a drop in their systemic blood pressure, and have symptoms from that. I don't want to do that. Okay, conclusion. You don't need a tilt test for most of the things we do, but we like to do them for factors other than they generate income. They inform us. They really help guide therapy, and not only that, help as a marker for dysautonomia in general. In some cases, like fainting, we can make a decision for a pacemaker. I just had a lady who was 45 who had a number of faints. She was turned away by all the doctors, told just drink a lot of fluid and take salt. And finally, she has a nurse practitioner as a cousin. She had her take the tilt test. She had an 18-second asystole. So she's getting a pacemaker. Okay, thank you very much.